On-the-scene coverage of AHA 13 is supported by Janssen Pharmaceuticals Incorporated.
We're here on the scene at AHA 2013. I'm Chris Cannon, and here with Tony DiMera from UC San Diego. And we have two studies looking at cooling patients in cardiac arrest. This has become, as we know, a standard of care. And there are two further nuances that have been explored, the idea of pre-hospital cooling, and then also what degree of cooling should one aim for. So I think beginning with the pre-hospital, we had a study here from Washington on looking at whether early intervention in the ambulance could work.
Right, from the Seattle area, an interesting concept of whether or not if you cooled a patient, a post-arrest patient, right from the start, even in the ambulance, if you could produce a benefit either in survival or in neurologic function following presumed survival. And so the cooling really was relatively modest. It was a couple of liters of 4-degree saline. So it was intravenous administration of saline, something you could do in an ambulance. You couldn't put in a cooling catheter. And then the patients were taken to the hospital and treated appropriately with abrupt and 3-month outcomes in terms of survival and neurologic function. Now, this study was negative. I feel like, that's a recurring theme, right? It was a negative study in that, in fact, there was no benefit that was recognized in the patients who received the cooling. However, as I looked at the data, the cooling was really less than 1 degree, and it was in the vicinity of 35 to 36 degrees, so that it was something that was achievable rapidly as soon as the patient was seen, but perhaps not of a sufficient magnitude to produce a benefit.
Yeah, certainly the modest intervention. I was thinking it's just like, do you go around with the good humor truck and throw people in there as you go to the ambulance to the hospital? But I think, building on that, then a second study looked at the exact degree, but using monitoring with 33 as a new low target for the temperature versus 36, which has been used in some of the other target studies. And you want to summarize that one?
Yeah, exactly. That was a smaller study that was conducted in Sweden, but with the specific question of whether or not if you cooled patients to 33 degrees rather than 36 degrees, that you'd get a benefit, or what magnitude of cooling really would be beneficial. And so this was accomplished by a cooling catheter. So the typical IVC cooling device, along with other maneuvers in post arrest patients who were largely non-responsive when they arrived at the emergency room. Again, looking at survival and neurological function, and again, I hate to say, again being negative.
Well, it's, I think, a very important question to ask of exactly how precise does one have to be in cooling. The prior studies have shown cooling versus not have been beneficial, and then it looks like that's the major effect, and we don't have to get too cold, and we certainly don't have to freeze the patient. So, I think it is a contribution.
Yeah, the one caveat, of course, is that in the Seattle study, there was a higher incidence of pulmonary edema and a higher incidence of recurrent arrest in the patients who were cooled. So that if you ask the question, well, cooling may not be a benefit, but is it a deficit? and in fact, it appears that perhaps there could be some difficulties. Now, this wasn't seen in the other trial, nor was it seen in the CHILL-MI trial that was recently presented at the TCT meeting.
Yeah, and so potentially in that pre-hospital, the 2 liters of cold saline, that the 2 liters could have been the problem. So I guess some issue of how that's achieved is certainly a factor in the overall outcomes.
Yeah, no question about it. This is, I think, an important morning here at the American Heart Association for what not to do.
Fair enough. Well, from AHA in Dallas, on the scene, I'm Chris Cannon with Tony DiMaria.